Assalamu alaikum wa rahmatullah. So for our third lecture, in the last lecture, we already talked about the basic principles of fractures. Now we're going to talk about the complications of the fractures. It's going to be local and the general. We will be starting by the local complications of fractures. It can be divided into early and late. So the local complication, it's either early or late. Early, it means that it's part of the primary injury. Late is either after weeks or days. So for the local complication of fractures, we have the urgent, less urgent, and the late. For the urgent, we have for sure the visceral injury, vascular injury, nerve injury, compartment syndrome is very important, and we will talk about it later. HAEMARTHROSIS, which is blood inside the joint, infection, and gas gangrene. For the less urgent complications, we have fracture blisters. After a high energy trauma for the soft tissue, we may see some blisters on the soft tissue. We will talk about it in a bit. Plaster sores, which is also like pressure sores, nerve entrapment, myositis esophagens, and we will talk about it for sure. Ligament injury, tendon lesions, joint stiffness, very important, algodystrophy. For the late, delayed union, MALUNIon and non-union, avascular necrosis, muscle contracture, joint instability, and osteoarthritis. So for the visceral injury, it's very important, we talked in the first lecture that the rib cage, for example, it's protecting the major organs like the heart, the lungs. So if you have a fracture in the rib cage, it might induce penetration for the lung, and it may cause pneumothorax or tension pneumothorax, which is a life-threatening condition. In the pelvis fractures, we may have like bladder injury. So these visceral organs are important to spot diagnose immediately and treat in the primary survey in the ATLS protocol we already talked about. Now, common fractures are really associated with major arteries, like around the knee and the elbow. It's very, very common, humerus and the femoral shaft. So the artery, it's not always torn, it's not always cut. So it might be cut, it might be torn, it might be compressed only or contused. So if you have a patient and you don't feel the pulse, it's not mandatory that the artery is cut. It may be torn, it may be compressed or contused. Even if its outward appearance is normal, okay, even if you look at the artery and you see it in the outer shape is normal, that does not mean there is no injury. Okay, this table is very important, the fracture and the vessel. If you have a fracture in the first rib, the subclavian artery is one of the most common to be injured. Shoulder dislocation, very common. One of the most common joints to be dislocated is the shoulder. So with shoulder dislocation, you may have axillary artery injury. Humerus supracondylar fracture, you may get your brachial artery injured, also elbow dislocation. In the pelvic fracture, the parasacral and internal iliac. The most common cause of bleeding in the pelvic injuries, usually venous. But if it's arterial, you will think about the presacral and the internal iliac artery. For the femoral supracondylar fracture, you will think about the femoral artery. If you're thinking about the knee dislocation, popliteal artery, it's very common, and you have to diagnose it because it has a lot of morbidity. The proximal tibia, popliteal artery, and its branches. Okay, how can I diagnose a patient with a vascular injury? Now, for sure, you all know the 5 Ps. So we have paresthesia or numbness because there is no much blood supply is going to the limb. So you will start feeling numbness and paresthesia. It's like when you're sitting on your leg for a long time, you will start to feel paresthesia or numbness. It can be cold or pale and slightly cyanosed, okay? And sometimes the pulse, you can't feel it. So that's why we always tell the students that you have to examine the distal neurovascular. Okay, if you have an X-ray and you see it is a high energy trauma, severely comminuted, it will give you an indication that this patient might have a vascular injury. What to do if you have a vascular injury? If the fracture is not reduced, the first thing to do is reduce the fracture, then re-examine again. After examination, if it did not came back, you can do angiogram. So you can consult later the vascular surgeon. For sure, if you have the pulses absent, what to do? The first thing to do, remove the dressing. Because one of the most common things to compromise the blood supply is the dressing we already put. So please remove the splints, remove the bandage, do an X-ray another time, check the position, check the reduction of the fracture. If the fracture was displayed, there is no pulse. If you reduce it, most probably the pulse will come back because most of the time the artery is already kinked. It's not cut, it's only kinked. If there is no improvement, either exploration or angiography after contacting your vascular surgeon. This is some pictures. You can see in this picture that in the humerus fracture, the radial nerve might be injured. In the high tibial or proximal tibial fractures, the tibial nerve might be injured. And you can see here in the proximal ulnar fracture, the ulna or radius, ulnar nerve or radial nerve, or either the posterior interosseous nerve could be injured. This table is important also as the vascular injury. This is for the nerve injury. Shoulder dislocation, the axillary nerve. Humeral shaft fracture, very common. Radial nerve, because you know the radial nerve is going from the medial side, and as it's going distally, it's going to the lateral. So it's going in the spiral groove around the humerus. So in the mid-shaft humeral fracture, you have to think about the radial nerve injury. Supracondylar fracture is either radial or medial. Elbow medial condyle, you know, it could be the ulnar nerve. Montegia fracture, which is dislocation, anterior dislocation or posterior, lateral dislocation of the radial head with ulnar fracture. So you should think about posterior interosseous nerve. In hip dislocations, it depends on the position of the hip dislocation. It's either anterior, posterior, or central. But if it's posterior, you will think about the sciatic nerve, and for the knee dislocation, the common peroneal nerve. Okay, for the nerve injury, usually if they say if it's closed injury, there is no opening in the skin, you should observe. You can observe because 90%, the studies shown that 90% of these people will regain the function of their nerves in about 4 months. So if recovery did not occur, you can do the EMG and you can check for evidence for recovery. After that, you can do the exploration. If it's open fracture, you can do debridement, repair, then you can look for the nerve and you can find it if it's injured or not. If it's injured, you can primary repair. In acute nerve compressions, for example, around the wrist, which is the median nerve, like the carpal tunnel syndrome, the patient will be complaining from numbness, paresthesia, painness. So these signs and symptoms will give you, along with the history, physical examination, and these symptoms will lead you to the acute nerve compression, which you have to go and decompress the nerve. For example, the median nerve, you have to go and to decompress the carpal tunnel by the retinaculum. Okay. Indications for exploration. If the nerve injury associated with an open fracture, you go and do debridement, and you do the nerve injury. Fractures that need already internal fixation. For example, if we have a patient with mid-shaft humerus fracture and he's having register drop, and you want to go and fix, when you open your incision and you go through your approach, you have to check for the radial nerve that it's intact. Then you can put your plate on. And if it's not intact, you can repair it. If there is any concomitant like vascular injury, so if the vascular surgery is going already in, he wants to do repair, you can go and do your repair too. And if you have a nerve damage diagnosed after manipulation. So the patient is moving normally. He's having, for example, a mid-shaft forearm fracture. You did the reduction. Now he's not moving his hand, okay? And you diagnose him with nerve injury. You can go and do exploration. Very, very, very important the compartment syndrome. Okay, so what's compartment syndrome? As simple as that, compartment syndrome is an increased pressure in the osteofacial compartment. This is the simple definition. What's compartment syndrome? Increased pressure in the osteofacial compartment. So after fracture, high energy trauma, burns, all of these cases will induce inflammatory process that will increase the pressure inside the compartment. You all know that the muscles are covered by fascia, and the fascia is a dense fibrous tissue. So whenever you have a trauma, there will be inflammation inside, more fluids going in, the pressure will go up, up, up until it compromises the blood flow, and compartment syndrome will basically happen. The problem is, if you don't treat compartment syndrome, you will end by something called Volkmann's ischemic contracture, dead muscles, non-mobile limb, and that's it. Anatomy is very important. You have to know the anatomy of your limbs so you can diagnose compartment syndrome. The most important compartments to know are in the leg, the thigh, the forearm, and the hand, because these are the most common places. So for example, if you look at the leg, it has 4 compartments: the anterior, lateral, superficial, posterior, and deep posterior compartment. And you should know the content of each compartment. For example, the forearm, you have the dorsal and the volar. The thigh, there are 3, anterior, medial, and posterior. And you should know also the components of these compartments. It's very important to know that the normal compartment pressure inside the compartment, the pressure should be from 0 to 10, sorry, 0 to 10. So this is the normal intercompartmental pressure. If it rises into 20 millimeter Hg, the capillary flow will be decreased. More than 30 to 40, now we're gonna have damage to the muscles and the nerve, and ischemic necrosis will happen. So the first structure to be affected by compartment syndrome are the nerves. That's why pain, paresthesia, pain is very important. Even if the elevated compartment pressure, arteries and arterioles are not affected at first, but they will be late. As you can see here in the diagram, this is the pathophysiology of the compartment. You can see there's bleeding, and after that, it will go to increased pressure within the compartment, then the decrease of blood flow, which will result in muscle ischemia, more edema, greater pressure, and it will go profound ischemia, which is called the vicious cycle. So the more compromisation, more pressure, less blood, and that's it. It's going around and around until Volkmann ischemic contracture happens. Okay, very important. How to diagnose compartment syndrome? Basically, the most important is clinical features. So you should look at your fracture. Is it a high-risk injury? Fracture of the elbow, of the tibia, forearm, multiple fractures, high-energy trauma, crush syndrome. So all of these are giving you a tip that this is a high-energy trauma. Okay. The 5 P's that we already talked about: pain, paresthesia, pallor, paralysis, and pulsionismus. These are hard signs that are telling you, be careful, there is compartment. For sure, you don't have to wait for all of the 5 to come, because if you are waiting, you already have a dead limb. So don't wait for the 5 P's to come. You have to expect compartment. So the earliest and the classical feature of a compartment syndrome is, this is a common question, pain and pain and pain. Pain is very important. So pain, altered sensibility, paresis. Okay. Ischemic muscle is highly sensitive to stretch. That's why they say it's pain with passive stretching of the compartment. So let's take an example. If the patient is having compartment in the volar aspect, or the volar compartment of the forearm, if I'm doing this, this is called flexion. I'm not stretching the muscles. So when I want to stretch the volar compartment, I have to do extension. So I'm extending now my wrist, I'm getting more tension on the muscles. And vice versa, if I want to test the dorsal compartment, I should do flexion, so I'm stretching this compartment. So passive stretching will induce more pain. Okay. What if your patient is unconscious? There will be no pain. So if he's a multi-trauma patient and you are looking at the lower limb, it's swollen, how can you confirm it's compartment or not? For sure, history, X-ray, physical examination, you have to check for pulses, but the patient is not complaining of pain. That's why we have something called the intracompartmental pressure. We have like a catheter, we introduce it inside the compartment and we measure the compartment. Is this enough? No. So for example, if we have like the pressure inside the compartment was 30, is this compartment or no? We have to calculate something called the delta pressure. Delta pressure. So what's the delta pressure? It's the difference between the diastolic and the intracompartmental pressure. Again, so what's compartment? Or the delta P, it's the difference between the diastolic and the intracompartmental pressure. So let's take an example. A patient is, his blood pressure is 120/80. The intracompartmental pressure is 30. Is this a compartment? Not yet, because the difference is 50 between the 80 and the 30. If the patient's blood pressure is going down, the diastolic is 50, and the intracompartmental pressure is 30. So now the difference is 20. It's less than 30, so this is compartment. This is very important to keep in mind that patients who are in shock, that the blood pressure is going down, they have more risk to get compartment syndrome. So what to do for these patients? Give them blood, give them fluids, raise their blood pressure, the compartment will cease. Otherwise, you have to do fasciotomy. Okay. So we have something called the soft signs. Okay, soft signs. So the patient is complaining of pain. There is a bit of paresthesia. The pulses are weak. What to do? What to do for this patient? You can wait 30 minutes and re-examine, 30 minutes and re-examine. After 2 hours, if these signs did not relieve, you have to do something called fasciotomy. What's fasciotomy? Is opening of the fascias, the whole fascias of the limb. If the leg is involved, you have to open all the compartments, the anterior, lateral, and superficial, and the posterior. In the forearm, you have to open the whole compartment. It's very important. And there is no time to lose. Keep in mind, there is no time to lose. Okay. Now for treatment, for the treatment of compartment syndrome, is definitely decompression. You have to decompress. So the first thing to do, remove the cast, remove the bandage. Any dressing outside, you have to remove it. Okay, lie the limb flat. Don't elevate. If you elevate the limb, the pressure will go down. So the arteries are pushing blood. They can't reach the hand or the leg. That's why you have to keep it flat. You have to monitor the pressure if the patient is unconscious. And if you are suspecting that this patient is having compartment syndrome, go and do fasciotomy. It's better to do fasciotomy on a normal limb rather than wait on a compartment limb and to lose it. In this picture, on the X-ray, on this side, you can see that this man is having a high energy trauma. And it's very, very obvious that's having high energy trauma. You see comminuted fracture in the proximal tibia involving the intra-articular side with the fibular fracture. And if you look at his leg, you can see a lot of blisters. You can see these blisters. They are hemorrhagic blisters. So this patient is having high energy trauma, increased suspicion of compartment syndrome. What's the treatment? Surgery. Let's do fasciotomy. We open either 2 incisions or 1 incision. We open all the compartments. You see that it's very ugly surgery, but we have to save the limb. Okay, now we're done with the compartment syndrome. Let's go for the HAEMARTHROSIS. HAEMARTHROSIS, which is blood inside the joint. mostly because of a fracture. So any fracture involving a joint, it could have a blood inside, which is hemiarthrosis. Swelling, tins, and pain, decreased range of motion. What to do? You can aspirate and put ice. Infections, very important. Infections can happen. Infections can happen in closed fracture, but in open fractures, the rate is much, and the incidence is much higher. That's why you have to monitor your patient, and you should check for the post-traumatic wound infection and keep dressing, debridement, and keep it clean. You can give IV antibiotics within the first 3 hours, so you decrease the rate of the infection. Gas gangrene, gas gangrene is terrifying for the surgeons. Usually it's clostridial infections. It's very fast within the first 24 hours. This organism is producing toxins. These toxins will destroy the cells and will cause tissue necrosis. The clinical features, as I told you, it appears within the first 24 hours. Intense pain, swelling, brownish discharge. It has a characteristic smell, and you can see in this picture how the blisters is happening for this patient. It is essential to distinguish the gas gangrene, which is characterized by myonecrosis, for anaerobic cellulitis. So it's very important. Failure to recognize the difference may lead to unnecessary amputation. So it's very important to spot your diagnosis for these patients. How to prevent? Deep penetrating wounds. So this is history. Okay, you have to take history. Physical examination. Unhappily, there is no effective antitoxin against clostridial infections. So the treatment is early diagnosis, debridement. Fluids, intravenous antibiotics should be started immediately. Hyperbaric oxygen, very important. And unfortunately, sometimes we have to go for amputation. As you can see in this picture, this is a gas gangrene. On the right side, this is the X-ray. You can see how much gas in this X-ray. Fracture blisters. As you saw in some pictures that I already displayed here, you've seen some blood-stained and clear fluid. So what's the difference? Usually with the high energy trauma, the first thing to happen is to have clear fluid blisters. If the trauma is more severe, you will have blood-stained. Nowadays, they say there is no advantage to puncture the blisters. Sometimes we do it for the hemorrhagic. We clean them under sterile techniques and we cover them. Okay, plaster. So plaster pressure, sometimes, when you want to do reduction, for example, distal radius fracture, you want to hold your reduction, you put the POP, okay, or the plaster, and you mold it. So we hold the limb and we mold it until the fracture returns to the normal position. The problem here is that this molding sometimes will cause pressure, and this pressure will give you sores, as you see in these pictures. Look in here and there. So what to do? You have to open a window, okay, and do debridement and cleaning for these sores. So now we're done with the early complication. Let's go to the late. So for the late complication, we have something called delayed union, non-union, and malunion. So what's delayed union? You are expecting to see this fracture that's supposed to be healing, but it's not, or it's getting delayed. Why? Because of either biological, mechanical, or patient-related. The biological, either it's inadequate blood supply, severe soft tissue damage, or periosteal stripping. And you remember from the last lecture from the fracture management and the principles of fracture, I told you about periosteal stripping. The blood supply is very important for bone healing, and so on. Biomechanical, it's either imperfect splintage, the fracture is moving, or over rigid fixation. It's very rigid and the space is far, it's not less than 2 millimeters, as I told you last lecture. Could be infections, yes. Patient relation, the patient-related factors like immunosuppression, if he's taking like corticosteroids, any drugs, incooperative patient, and so on. For sure, fracture tenderness, if it persists, that means that the bone is not healing. So one of the most important signs that your fracture is getting healed, that pain is going away. And in X-ray, you should see callus formation, the line of the fracture, if it's the primary bone healing, should be disappearing. If it's not, so this is delayed healing. For the treatment, there are two important principles to eliminate any possible cause of delaying union. For example, the patient is moving his limb too much, you have to fix it. And to promote healing by giving more appropriate environment, okay? So you have to immobilize, okay? And you have to keep the muscles moving. How to immobilize and to keep the muscles movement? Either you give a brace, okay? Or you go for internal fixation. You fix the fracture. The other option, after the conservative, you can go for treatment. You have to go for internal fixation plus bone grafting. So it's not only enough to go for internal fixation, you have to put bone graft. So we bring bone either from the iliac crest, from anywhere in the body, we put it inside and we fix. Okay. So that was delayed union. What's non-union? Non-union, that there is nothing happening to the bone, okay? We have two types of the non-union. It's either hypertrophic or atrophic. This is the difference. On the left side, you can see the hypertrophic. That means there's good blood supply. The bone is trying to heal, but because of movement, it can't. On the right side, it's called atrophic. The atrophic, you can see on the distal and proximal ends, there is no new bone formation. That means that either the bone is fixed well, but the blood supply is not okay, or the biological environment is not okay. So the difference between these two, on the left side, good biological environment, a lot of movement. On the right side, there is no good biological environment. This is non-union, and this is malunion. Malunion means the bone healed, but in the wrong position. So you can see here that there is angulation. It's angulated. Okay, so when dealing with these problems of the non-union, they have an acronym. It's called the CASS, the CAS. So contact, was there sufficient contact? Was the two ends of the bone, they had contact, or it was far? There was lengthening or shortening. So length, alignment, and rotation another time. You remember from the last lecture, length, alignment, and rotation. So if there is contact, that's good. Alignment, there should be no angulation, not in varus, not in valgus. So it should be well aligned, there is contact, and it should be stable, not moving. You remember the cutting cones, when they want to move, there should be no movement. It should be rigid. So it should be stable. So contact, alignment, stability, and you have to do stimulation. How we can do stimulation? Sometimes if you have a femur fracture and you had a nail, you tell the patient to go and walk. Why to walk? So this is a femur, and the patient, when he's walking, he's putting compression. So what's happening at the end of the bones, it's having micro motion, not macro. Macro is not good. Micro will have compression. Wolff's law will work again. The Wolff's law that we mentioned in the last lecture, there will be bone formation and promoting to heal. For sure, you have to look for local infections, if the patient is taking any drugs, non-compliance, and poor soft tissue or high energy trauma. The soft tissue is not doing well. Usually we have to go for operative, usually for the non-union. What will happen in the non-union, that the patient will be having a pseudo-arthrosis, a new joint. For example, mid-shaft humerus fracture, he will be having another joint, moving, not painful, because the edges are healed. So in operative, we have to go for rigid fixation. We have to debride these ends of the bone, and we have to put bone graft. And if there is shortening, if the limb is shortened, now we have to add another techniques like Elizarov, which is an external fixator that we use to do lengthening. Malunion, as we already said, is healing in the wrong way. Sometimes we have to do fasciotomies and to re-put the bone in the alignment. For sure, there is something called like the accepted reduction. It's different from the adults, from the pediatrics, depending on the age, on the sex. So it's very important to keep in mind on each bone, what is the acceptable reduction. So sometimes we accept in the forearm, for example, 10 degrees of angulation. So if it's angulated 10 degrees, okay, we will tell the patient that it's okay, we will wait. Don't worry, it's gonna be healing normally. If it's more, we can't accept it, we have to reduce it. So upon these guidelines for each bone and limb, we can progress with the treatment. AVN is important, AVN, especially in the femoral neck fracture. So you have the femoral neck. If you have a fracture in the femoral neck, the head might have AVN because the blood is going from down to up, retrograde, through the retinacular arteries that's coming from the medial circumflex femoral artery. Also scaphoid fracture, because the blood is coming from distal to proximal, retrograde. The lunate and the talus, because it's covered by a lot of articular surface. So there is no much blood supply. Usually vessels cannot cross articular surface. That's why lunate and talus might have avascular necrosis. This X-ray shows here, on the right side, you can see the retinacular arteries that will be cut in the neck-of-femur fracture, which will cause avascular necrosis, as you see here. Clinically, mostly the patient acutely will not complain, then he will start having pain. On X-ray, you will have sclerosis. As you can see here, proximal pole of the scaphoid, you can see that it's more white than the other bones. Here you can see it's more white in the superior part of the femoral head because of the osteoarthritis and the sclerosis. And here on the right side, you can see the deformed head. The head is now shaped is like a triangle, you can see. Treatment. So treatment becomes necessary. Either we have two things, either the function is abnormal or the patient is having pain. So if the patient is having pain or the function is abnormal, it's time to treat. So what's the treatment for the AVN? Usually in the old ages, for example, in the neck of femur fracture, you have to go and replace. We put a bipolar or total hip. So we have to do arthroplasty. The more young, the more worse prognosis. And that's it. Growth disturbances, you know, in the pediatric age group, as we said in the last lecture, they have physis, and fractures through the physis may cause growth arrest and disturbances. Bed sores, because the patient is not moving on the same position, they will have sores. It's very difficult to treat. So the most important part to keep moving the patient and to put him on air mattress. Myositis esophagens is heterotropic ossification of muscles around the joint, usually elbow, hip. It's very common in these, it's not very common, it's the commonest around these joints. Usually swelling, soft tissue tenderness. We might give them some drugs to make it happen less. This is X-ray, you can find here the myositis esophagens. We can give them some indomethacin and radiotherapy to prevent recurrence. Tendonitis. Tendonitis, inflammation, so inflammation of the tendons. It might happen with any fracture. Nerve compression, as we already mentioned before, that the nerves might be compressed and we have to decompress. Muscular contractures, like Volkmann ischemic contracture with the compartment syndrome. And you can see, for example, for the hand, when you have absent blood supply, it will be fixed in this position. It's called intrinsic contracture of the hand. The MCP will be flexed, the PIP will be extended, and this is the position of the hand, as long as the leg or the foot on the right side in here. Joint instability, if there is ligamentous laxity, if there is muscle weakness or bone loss. Okay, this might cause joint instability. The most common joint to be dislocated, as you all know, shoulder and shoulder, and if recurrent dislocation is happening, we could have bancal lesion in the glenoid, or patella with lateral dislocation of the knee. Joint stiffness, really, joint stiffness is one of the most, like, the worst, really, complication you could have, because if you want to retain the joint into its range of motion, it's going to take a long time, effort, and really it's a nightmare for most of the surgeons. So what's the treatment of joint stiffness? Physiotherapy, physiotherapy, physiotherapy. You could go in with arthroscopic guided, and you do release of the fibrous tissue inside the joint. You might open it up, lengthening of some tendons and muscles plasty, and so on. Complex regional syndrome, it's very important. It was called Sudix atrophy, then reflex sympathetic dystrophy, then complex regional pain syndrome. We have many types, either from trauma or trauma to the nerve. As you can see in the picture on the right side, it's red, swollen, unable to move, and in the X-ray you can see these periarticular osteopenia. So these patients, usually we give them anti-inflammatory drugs, physiotherapy, and exercise. This is the most important. Osteoarthritis, we will have like a special lecture talking about osteoarthritis, but if the fracture is involving the articular surface and it is not reduced anatomically, there will be osteoarthritis. General complications, we have fat embolism, DVT or PE, atelectasis, tetanus, or crush syndrome. We're gonna go through them very fast. Fat embolism, because usually of long bones fractures, these small fat will go into the bloodstream until it arrives to the lungs. It will cause fat embolism, tachypnea, tachycardia, and you will have petechiae. So the petechia is the pathognomic sign of the fat embolism. In severe cases, they might have respiratory distress or coma, and the patient unfortunately might die. You have to give them supportive for sure therapy, high flow oxygen. Sometimes you have to intubate, and so on. For the PE, it's like, DVT or PE, you have to give them prophylaxis. Most of our patients that having hip surgeries, post fractures, you think that the patient is going to be bedridden for the next few weeks, you have to give them anticoagulants, okay? Anticoagulants, like low molecular weight heparin. You can give them, it's like Clexane or Inoheb. It's very important. And if the patient's having or taking oral contraceptive, it will increase the risk of DVT. It's very important to diagnose the DVT by CT, MRI, duplex ultrasound, and so on. If you diagnose them with DVT, you have to give them low molecular weight heparin, and sometimes you have to give them warfarin in addition, if there is no contraindication for sure. So the patient with PE might complaining from tachypnea, tachycardia, cyanosis, pleuritic or pleural flexion rub, hypoxemia, hemoptysis, and you all, I think, know these information. You have to give them supportive therapy with heparin. Atelectasis, collapse of the alveoli. Patient will present with hypoxemia. We encourage them to do chest physiotherapy with deep breathing, so they can open the alveoli again. Tetanus, when you have open fracture, you have to give tetanus toxoid, so you prevent tetanus disease, which is tonic by the start, and it will be later as clonus. And the most important muscles that are involved are the diaphragm, so the patient won't be able to breathe. That's why sometimes we give them IV antitoxins, and sometimes we sedate these patients and give them muscle relaxant, and we put them on ventilators so we can save their lives. Crush syndrome, you have a limb crushed, no blood is coming in. When the blood coming back again, it's called ischemia reperfusion syndrome. Myoglobinuria and oxygen radicals will go into the bloodstream. The myoglobin will go to the kidneys. They may cause kidney failure. The oxygen radicals will cause more injury. This is called thrush syndrome. Okay, what to do? Fluids, 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 antibiotics, and alkalinization of the urine. I hope it was easy lecture. I know it's long, but I hope it was okay. Thank you very much, and we'll see you in the next lecture.